Hello, everyone. This is Lauren Caton. I am a PhD student here at UNC Gillings. I work for the Maternal Health Learning Innovation Center. We're really excited to have everyone here, and it's going to be a really engaging panel. If you're wondering if you're in the right place, this is Engaging Level 1 Hospitals in a Pandemic, how Iowa recruited hospitals to join their AIM bundle. Thank you, Stephanie, for sharing the slides. I am going to do some brief introductions, and while I'm doing that, I would like to remind everyone, please keep yourself on mute. We've been doing this for so long now, and we all know the drill. If you want to ask a question at the end, you can unmute yourself, and please use the chat, make this as engaging as possible. I'm sure the speakers want to hear your questions too, kind of as you go, and we can field them at the end. Or something really resonates with you, feel free to clap, the little air clap sign that they have on here, or, type, that's great. We really want to make this engaging. So without further ado, I'm going to introduce Jill Henkle. Prior to working as a rural clinical improvement advisor for the IMQCC, Jill has worked as a medical surgical emergency department obstetrician and newborn staff nurse in rural critical access hospitals for over 25 years. She was recently the OB manager at Wayne County Hospital, where she assisted with implementation of maternal safety bundles, simulation drills, process improvement, and evidence-based staff education. She's an advocate for rural maternal hospital care and a champion for the use of maternal safety bundles. We also have Stephanie Radke on the call. Dr. Stephanie Radke is a board-certified obstetrician gynecologist in practice at U of I hospitals and clinics. She completed her medical degree also at U of I and her residency training at UC Davis. She was a community private practice in California for 3 years before returning back to U of I. She's active in quality improvement at her hospital and believes that this is a key path towards achieving health equity. She's the co-founder and medical director for the Iowa Maternal Care Collaborative and Iowa Alliance for Innovation on Maternal Health, Iowa AIM. So both programs are initiated with the support of Iowa's MHI award, which we'll talk about today. We also have Stephanie Trusty on the call. Stephanie has worked at IDPH for 16 years as a maternal health nurse clinician and serves as the AIM state lead coordinator for Iowa's AIM program since October 2020. Prior to this work, she worked for 28 years at Unity Point Methodist, providing inpatient direct care as a staff nurse and the NICU team as a labor and delivery nurse, and followed this time up as a maternal health outreach coordinator and interim nurse manager for the OB unit. So in summary, we have a wealth of knowledge and experience on this call today, and I encourage everyone to listen in, pick their brains at the end, and we're just excited to have you here. So I will let the team kick it off whenever they're ready.
Thank you so much, Lauren, for the intro. So I will start us off. As mentioned in our bios, here in Iowa, we are really fortunate to be supported by a HRSA MHI award that has supported our work. And so just want to remind everybody that what we are talking about doesn't necessarily reflect HRSA. And then we will also be talking about the AIM program, which is also funded in the same bureau as we've heard about during this conference. So our objectives for this session are to help audience members identify strategies for how you might engage lower volume or rural facilities in the AIM program, or really in any sort of improvement work that you're seeking to do. We will discuss the required resources to successfully engage with these this kind of category of hospital, evaluate the impact of hospital engagement, and then kind of bring it together in thinking about how principles of community-based participatory research, even though we're not talking about research, but how some of these engagement principles can be applied more broadly to engagement with hospitals and other stakeholders in your communities. So I'm going to start us off by first talking a little bit about Iowa. So on average, we have approximately 40,000 births each year that occur in Iowa. We're obviously a small rural state, and we are seeing a slight decline in the number of births occurring in our state each year. We currently have 57 open labor and delivery units in our state. However, that is a significant decline in the past 10 years or so, with loss of many rural and small town labor and delivery units. The majority of our population is in metro areas, but since we are a largely rural state, we do have pretty sizable rural and small town populations when pooled together. And our rural facilities in Iowa are often staffed by family medicine physicians providing obstetrical care, some of whom perform cesarean sections and others do not. In some facilities, general surgeons are the cesarean delivery providers who work in partnership with family physicians. And as I mentioned, we're a Maternal Health Innovation Awardee, and we are a new AIM state as of October of 2020. So for a little bit of background, here is a map of Iowa showing all of our 99 counties. And you can see this map is showing which counties have a labor and delivery unit. So you can see in 2000, 77 of our 99 counties had an open labor and delivery unit. That is not exactly the same number of labor and delivery units because several of our metro areas have more than one hospital with a labor and delivery unit. But we're looking at this to kind of show where geographically are services available and where are they not. So this is kind of the landscape in 2000. The majority of our communities had a labor and delivery unit available in close proximity. And then if we look in 2010, we can see that we've had 12 facilities or 12 counties lose their only facility. In some communities, there may be a loss of a facility, but a second facility remains open in that community, so they would remain green. So the red are the counties that no longer have labor and delivery units. And then by 2020, you can see that our landscape is really drastically changing in Iowa. We had really an accelerated rate of closures in rural communities. And we also started to see closures in communities that are not rural, that are more micropolitan or even metropolitan, depending on kind of which system of classification of rurality you are looking at. So this is kind of the backdrop to Iowa becoming an AIM state, is that we are seeing a lot of movement in where we have facilities available. So when we think about why labor and delivery units close and how that's relevant to our work that we are doing with AIM, we know that there's a lot of reasons that can factor in, and it's often multiple factors. Some facilities close due to financial concerns related to costs exceeding what they are reimbursed. Some facilities in Iowa have closed because they do not have somebody to perform cesarean sections. For example, they might have only had a general surgeon and that person retires. There can be other types of staffing concerns, such as nursing staffing with skills for labor and delivery, or anesthesia availability overnight in a small facility. But one of the concerns that we are hoping to address, and the reason I wanted to introduce that we are seeing these closures here, is that concerns about the quality of care provided and the competency of staff has been cited by hospital CEOs in Iowa as one of the reasons why they have closed or that they might consider closing. So this is where we felt like engaging these facilities was really important and may help us maintain care availability in Iowa. So this map is looking at the rurality or urbanicity, depending on which way you want to look at your scale, of counties in Iowa. So the dark teal counties are classified as rural, meaning that there is not a population center of at least 10,000 people. The lighter green is micropolitan communities. So in these counties, there is a population center between 10 and 50,000 people. And then our darker green are our metropolitan counties. And these are places where there is a population center of at least 50,000 people. So as you can see in some of our metro areas, there's multiple hospitals. clustered there. And so each black dot is an open labor and delivery unit as of really this month. And you can see where they are. So we do have quite a few rural facilities that are open. When we think about our population, even though like any place, our population is centered in the metro area, and that's where the people who are giving birth are largely concentrated. As I mentioned, because we are such a rural state, we do really still have kind of a sizable minority, if you will, of our population who are giving birth, who reside in either rural or micropolitan areas. And so to exclude this community or to not actively engage them with our work would really be ignoring a large portion of our population giving birth in Iowa. We also know that the non-metro population can face different challenges as compared to metro population. So this is collapsing our micropolitan and our rural together. But you can see that we have a greater portion of Medicaid paid births in non-metro populations in Iowa. Our non-metro population tends to be perhaps a little bit younger, and also achieves a little bit lower level of education. We see a lot more advanced degrees in our metro area. This is pretty typical of the entire country, but we do see that here in Iowa. We see that there's certainly more racial ethnic diversity in our metro population, but we do have not insignificant diversity in our non-metro areas, especially with Hispanic populations in the rural communities. That is often part of our farming communities here. But this is one of the things that I think makes it really important for us in Iowa to make sure that we not just don't exclude our non-metropolitan birthing facilities, but we actively engage them, is when we look at our population and where they live and their pregnancy outcomes. So here are severe maternal morbidity rates, aggregate 2016 to 2019. You see that actually our metro population has the best outcomes in our state. Our small town Iowans are having the worst outcomes, and then our rural residents are sort of in between. These are unadjusted rates. We do know that there is a significantly larger portion of Medicaid paid births in the micropolitan group than the rural group, but I think kind of demonstrates that there may be some social determinants that underline some of this, but there's a lot of opportunity to address some of these rural-urban disparities through a program like AIM. So our first AIM initiative here in Iowa is to reduce our NTSB cesarean birth rate using the AIM Safe Prevention of Primary Cesarean Birth bundle. So each of the lines here is one of our hospitals. And you can see they're color coded by their annual birth volume. And you can see that there's really an extremely wide range of primary or NTSB or low risk cesarean birth rates across our facilities, indicating that there's a lot of potential for improvement in some of our higher C-section rate facilities. But if you look at, some of these low volume facilities are really what's populating some of the highest end of this graph. And so I think indicates that there's a lot of room for improvement in some of the small facilities. We also have some really highly performing small facilities that we can look to as local experts. And we're going to be talking primarily in this session about how we recruited facilities and really made them feel like AIM was for them. And so this is the same graph, but just color coding to show who we were able to recruit to participate in our improvement collaborative. All right, and I'm going to turn things over to Staff Trusty for the next section.
Thanks, Dr. Radke. So as Dr. Radke mentioned, we are new to this statewide quality improvement collaborative work. We had our first IMQCC meeting in May of last year, and we joined AIM as an AIM state in October of last year, and chose our first safety bundle as reducing the primary C-section birth. And we did add the 5th R of respectful care, targeting improvement of the patient care experience as something that our hospitals could choose to work on if they wanted in their quality improvement work. This was the top choice voted on by our birthing hospitals. And we were thrilled to have 43 of 57 birthing hospitals participate in our AIM Safety Bundle, and that represents 93% of the births in Iowa. Next slide. We did choose a framework for improvement to support local capacity for QI. This was a selling point for rural hospitals, and that we could help increase their knowledge in quality improvement. And to do that, we contracted with the Institute for Healthcare Improvement to first kind of inform ourselves. The IHI's goal for us in contracting with them was to equip us to operate a successful collaborative improvement project and to increase our confidence and ability to teach and use the model for improvement, so that even the rural hospitals could replicate the successful methods and participate in collaborative learning. Next slide. This is a busy slide, but it does represent the collaborative framework that IHI taught us and that we've shared with our collaborative hospitals. It's based on a cycle of all team calls and meetings at regular intervals, and it's depicted in the graph that you see. So it starts on the top left, selecting a topic, and we chose safely reducing low-risk C-sections. We did have an expert meeting, and we included a family practice physician from a rural hospital in our expert meeting, along with the healthcare system leaders in our state, a patient, midwives. We also included hospitals who had successfully achieved good low NTSB C-section rates, and they really gave us input in our planning for our first learning session, which you can see in the squares on the graph, LS1, LS2, LS3. Those are initials for when we bring all of the hospitals together. So our learning session 1 was held in May 24th and 25th. And really what we tried to do at that first learning session, based on the IHI model, was helping hospitals to learn what we were trying to accomplish. So building that will to change. And that was kind of easy with reducing C-sections, because high C-section levels relate to high morbidity and mortality. And so we could really say we're saving lives and also saving costs. So, also improving the patient experience by having a vaginal birth. So we also wanted to help them understand how we will know when the changes is an improvement. So we talked a lot at learning session 1 about data collection and reporting, because that's how we know that we are improving, is through data. And then also what changes will result in improvement. And we did develop, with IHI's help, a change package and driver diagrams, which are both organized tools to help hospitals understand the theory and the ideas behind evidence-based improvement efforts. And then hopefully we will, by next March, be to the point where we can celebrate our reduced low risk C-section rates, and discuss how to hold those gains and be sustainable. Next slide. This is our organization chart, if you will, for our IMQCC. And it does show our leadership team at the bottom, then our stakeholder advisory group, and that does include a community advisory board of women with a lived experience, our birthing hospitals that are participating in our safety bundles. And I also wanted to point out our subcommittees on the right-hand side, and that does include a level 1 hospital working group. We're really just getting started with some of this subcommittee work because we focused a lot of attention on getting our IMQCC and AIM off the ground. But we do want to, we have identified a physician leader and certified nurse anesthetist, since many of our rural hospitals use them to provide anesthesia for cesarean births. So we will be building that team soon. Next slide. And this just represents the AIM foundational elements in supporting structure and improvement. And it includes the 5 R's: readiness, recognition, response, and reporting, with respectful care at the center. And so we did include respectful care hadn't been added yet to our safety bundle that we chose by AIM yet, but we did want to offer that and have provided all of our birthing hospitals resources in skin to skin, trying to include the support person in the OR and some other ideas that they could implement in their quality improvement initiatives. Next slide. I think one of our primary successes for engaging rural hospitals was we really looked at our data, and 36 of Iowa's 57 birthing hospitals are really level 1, low volume, community-based hospitals. And of these, we were able to recruit 24 rural level 1 hospitals, or 66%, that are currently participating in our collaborative. So we viewed that as a real early win of our program. We also recognize that rural hospitals in our state represent 56% of the total number of birthing hospitals currently, and we want to encourage them and support them, and felt that it was essential for us to include them to be a success. We also felt early on that we needed to identify those nurse managers so we could recruit hospitals to our participate in our AIM safety bundle. And so we utilized our existing statewide structure. We have a statewide perinatal care program that's been in existence for probably around 40 years in our state. They visit birthing hospitals all over our state. They're based out of the University of Iowa with funding from the Iowa Department of Public Health through our Title V block grant. And so they had email addresses and contacts for the nurse managers. But I did want to mention, if you don't have such a structure in your state, one thing you might want to consider and reach out is your newborn metabolic screening program and your early hearing detection and intervention programs based at probably your Iowa Department of, or your Department of Public Health, state Department of Public Health would more than likely be willing to share with you their lists of hospital managers because they do frequently communicate with birthing hospitals all over the state. Another key success was hiring Jill Henkle, which you're going to hear from shortly. And so Amy Dunbar and Jill, along with myself and Dr. Radke, are improvement advisors for our hospitals. Next slide. We also planned resources to engage our hospital teams. As I mentioned, we do have an improvement advisor for each hospital. We developed educational materials that are posted both on our IMQCC website. And we also printed in hard copy our resources in a binder and mailed them to each hospital manager that signed our participation agreement. We try to do regular communication through our listserv, through our IMKCC website, and we also purchased Simple QI, quality improvement platform to support communication, not only with our team, but also it helps the team to have collaborative communication amongst each other and see the work that the other teams are doing. Next slide. So I already went over the collaborative framework and our cycle of team meetings with action cycles where teams are working on PDSA cycles in between the learning sessions. From our QI software, we currently have over 90 PDSA cycles going on right now. We also have monthly all team calls via Zoom. And we intersperse a topic of interest for our overall collaborative with team sharing time. And we try to really include our rural hospitals in the team sharing portion. We also promote easy reporting of data from our teams through the use of our REDCap survey. Next slide. And then some other key resources that we shared with our teams since many of the NTSV C-sections are done for non-progress in labor and concerns for how the fetus is tolerating labor. We shared expert guidelines and algorithms from national leaders, and also information on family-centered care and support. One other early learned lesson from our team that I did want to share also is in regard to communication. We do have Nicole, who's a critical member of our AIM program and is our coordinator. And we learned that we really needed to have her be the person who shared all the emails with the hospitals. Hospitals tend to have very robust filters. And when we had different people trying to send out emails, we found that our communication was really just going to the nurse manager's junk or spam folders, and they weren't receiving it. So this is just a really one important tip for your success, is to have a single point of contact that is emailing out to your birthing hospitals. We also use a listserv, and as I mentioned, our IMQCC website. And one other early success was engaging our hospital systems. So in Iowa, the University of Iowa Hospitals and Clinics have some affiliates. We have a Mercy system, and we have a Unity Point system. And by engaging their quality improvement leaders, they partnered with us to support rural participation. And in fact, at least two of the teams that I am working with joined because the quality improvement person from their system encouraged them to sign up and participate. And they do provide some ongoing support as well. And then we also try to get our hospitals administrative support by presenting to CEO OB hospital working group through our Iowa Hospital Association. And next slide, I'm going to turn it over to Jill Henkle.
Hi, everybody. I have to tell you, I live in about the most rural part of Iowa you can get. So if I freeze, I got backup. So is this heaven? No, this is Iowa. As you know, this is a pretty famous quote from a really famous movie, Field of Dreams, which was actually filmed in Iowa. We got some really good national attention in the last month or so. So I am honored and blessed to be the Rural Clinical Advisor for the INQCC. Next slide. So what is my role? So my role is to engage rural low volume birthing facilities to join our collaborative and to be their voice and advocate for these hospitals. So why did they pick me? Well, I could tell you a lot of fun stories, but for the sake of time, I won't. But I was a staff nurse in a critical access birthing hospital for greater than 25 years. I've only worked in critical access hospitals, don't know anything different. I still work PRN at our local hospital. I was a manager at our local hospital for 10 years and then left to do some travel nursing. I only did travel nursing in critical access hospitals. And so then when this opportunity presented itself, I was honored to be picked to be their rural clinical advisor. I am not shy about giving my advice, voicing my opinions, but the most important part of me is that I'm passionate about keeping rural maternity care open in our state and also nationally because it's an ongoing problem. So next slide. So this is just kind of another map of Iowa with our AIM participating hospitals by county. And if you remember the previous where we kind of took a really big decline in about 2018 of our hospitals and a lot of the rural hospitals did close at that time. So this is just kind of giving you a picture of where our AIM our participating AIM hospitals are. And then this just kind of gives you the urbanicity of the different AIM hospitals. The light green is the rural level 1 hospitals that we support. So next slide. So I don't know how many of you on the call know what a critical access hospital is. Just a quick definition of critical access hospitals is they have less than 25 beds in their entire hospital. So some might have, you know, there's all different levels of critical access hospitals, but the max amount they can have is 25 beds. They are located more than 20 or 35 miles from another hospital, but there are some exceptions that apply in that credentialing. And then they maintain an annual average length of stay of 96 hours or less for acute care patients, and they must provide 24/7 emergency care services. So why do I want to explain what a critical access hospital is? Well, because a critical access hospital doesn't have the resources that a larger or even a tertiary unit would have when it comes to delivering babies and managing emergencies. You know, staffing is a challenge. And there's just a lot of barriers when we talk about maternity care in a critical access hospital. Okay, next slide. So when we start talking to our hospitals, we really wanted to stress what the benefits of participation was in this collaborative. Teaching them the quality improvement science, which was totally brand new to me. And I attended a lot of the I classes, which was so instrumental in me learning about quality improvement science and being able to coach my teams. And then a PDSA cycle. Had never heard of one in my life. I found out that I do a lot of them, had never heard of what a PDSA cycle was. And then how to learn to start very, very small before we went really, really big and how important that is. And then how they can be used, how this can be used in future QI projects. I already have a team that I'm coaching that she's using the improvement science and her PDSAs to introduce QBL in the OR. And so she was like, I don't know that I could have done it without this. And so we were, it's very important that they know that this is also going to how they're going to do quality improvement in the future. And then simulations was so important in part of this. We all know that simulations are important in promoting maternal safety and in the bundles, it's a part of the bundles. But how we tied in simulations with our improvement process. And I'll explain a little bit more about that in another slide. So next slide. So some of the barriers that we looked at or we identified really early on when we started looking at how we were going to engage these rural facilities was time. Time is, right now that's a premium, even in more in a pandemic. How are they were going to do their data, how they were going to do their PDSAs, how they were going to do their measures, and how to let them know that the time invested was going to be a really, really great return in the support and the information that they were going to get. The other thing, as previously mentioned, a lot of the providers in these small critical access hospitals, they wear multiple hats too. They might work part ED. They are usually family practice providers, so they have a family practice clinic. Some of them do their own hospital rounds. So if you think about all of that, their time as providers were very, very minimal, and how we were going to make the best of that time. And then in a critical access hospital, managers are also staff nurses. And so when I worked as a manager, I was required to schedule myself 24 hours a week on the floor. And so that, you don't have time just to sit at a desk and, do your QI improvement and do your process measures and do your reporting. You have to figure out how you're going to do that in the limited time that you have. And then, how are we going to engage these facilities, and how these facilities were going to do PDSAs when they have very few deliveries. And then how to make data easily reportable, which we've kind of already discussed. So one of the things when we talked about engaging the facilities was using simulation and PDSAs. And so one of the best examples I can give is I had a team that wanted to implement skin to skin in the OR. And so they really had no idea really how to do that. And so we talked through it, and we talked about just maybe like at the end of shift, when surgery was over, that they could go in and just do a quick run through and maybe use a staff member as their patient and just kind of look to see how everything was what their processes they need to improve on. And, they found a lot of places where they could improve, from where, anesthesia machine was, where their warmer was, where the support person was going to end up as that baby was, taken out of the person's abdomen and put skin to skin, and how that was going to work. And then the other thing we did was monthly coaching calls, which we've kind of already talked about in a previous slide, where that was really important for engagement. And then we did open office hours where we would just send out Zoom links, and we're still doing them. But we did find out we kind of did our own PDSAs where we kind of tried to figure out where times were. So if anybody wants to learn from our mistakes, do not schedule them between 8 and 10 in the morning and after 4 at night. So we've kind of found out that noon works kind of the best for everybody. And then we did interactive workshops, because that was one of the things the CNO or the CEOs really were concerned about, is how do we keep these rural hospitals, the nurses competent, and like the slide said, how do we keep these rural facilities open? And so we would identify early on, just from listening to our teams talk, one of the things that we discovered early on is they weren't comfortable doing PDSAs. And so we did a workshop where we took the planning form and the PDSA and showed them how they work together. Probably the biggest thing was teaching task and test. That was probably one of the earliest things that we had to kind of talk them through, because everybody wanted to do task with their PDSAs. We did find during that it was really important that they did educate their staff and their providers all together before they did PDSAs in small facilities, because you might have 2 providers, you might have 10 nurses, and everybody kind of needs to know what's going on, because the PDSAs don't always present themselves, and everybody really kind of needed to know what was going on so they could do this. And then, you know, facilities similar to size, to collaborate. And we are still working on that. I always say that it's kind of like being at a conference and sitting around a table at noon, and you just start talking and collaborating. And so we're trying to get that. We've seen more in the last few office hours that we've had, where we've had a lot more collaboration with our facilities and our teams. And then data, we've kind of already talked about that. The one thing we did go to was quarterly reporting, just so the data was more meaningful. It was a little easier for them to do it, knowing they only had to do it quarterly. And then also, you know, their structure measures, quarterly reporting of their structure measures. The one thing we did ask them to do was continue reporting out monthly. We found out nobody wanted to, at least when we got our first report, I think I had 2 teams out of, and I think I coached 16 teams, 2 teams that reported. And so I'm like, okay, why are they not? And so I was kind of visiting one team, and she said, well, it's kind of like doing care plans in nursing school. I don't like to do them. I don't want to do them. And so what we did is we just kind of walked through that in one of our workshops, and how simple it is to do that status report. And then we talked about the use of our Simple QI platform, and then our IMQCC data dashboard. So those were kind of some of the ways we got through the barriers. Next slide. So this was probably the biggest thing that we did for these small rural hospitals, is really encourage them to do a multidisciplinary case review. And so this is one of the key structures that AIM does recommend for the bundle. And to meet monthly to review each case of an unplanned term primary section. Not only your NTSVs, but all of your primary C-sections. And look at your audit tools, and look at the best practice guidelines, facility guidelines, to see, were these really, did they meet criteria to do these C-sections? And then kind of ask, what might we have done different to alter this outcome? Could we have positioned them? Could we have waited a little bit longer? You know, just kind of talk through it as a team. And then what did we learn from this? And then also, what could we try to do different next time? Could we wait a little bit longer? Could we do some position? And that's one of the things that this collaborative has done, is we've started offering spinning babies to our facilities. And you know, we're already seeing wins with that positioning with the spinning babies. So that's a great thing that we're doing too. And then, you know, share your case review findings with your whole team. Bring your whole team in. You've got to have buy-in from the team. And I always said I always went to my staff and said, what do you, you know, what do you need? What can we do better? Because they are the ones that really are in the trenches and know what works and what doesn't work. Next slide. And so, you know, we've talked about collaboration. We've talked about how we gave them support, but listening is probably one of the most important things that we're doing for these rural facilities. I met with Peggy Brown, who is, she works with Nebraska AIM, and Nebraska is our neighbor, and they're very rural. I did not know how rural they were until I met with her. But she gave me some of the best advice. She said, just listen to them. At that time, when she started her position, she was able to go out, and she would just get her car and she would drive the facility. She'd meet with them, she'd talk with them, and she would just listen to them. And she said, know about their kids, know their hobbies, know their problems. They're going to talk to you about maybe stuff that's not even with the collaborative, but something support that they need in their facility. And so I have found that to be really true. We talk a lot of times about things that might not be collaborative related, but they know that we're listening, and we know that they're there. You know, really important building those relationships. Okay, next slide. So I'd like to share a success story of one of my teams. Next slide. So we have we had a level 1 critical access hospital. They average about 125 deliveries a year, which is pretty average. for an Iowa critical access hospital, and their NTSV C-section was 34.1%. Okay, next slide. That's kind of the background of one of my teams. So as they went on, and I can tell you, they were very, this was one of my teams that it was really hard for me to engage them. It was, I said it was kind of like me walking into my kitchen after an extended week of busy, and my dishes are stacked up and I don't want to look at anything. So I just walk back out the door. And I think that's kind of where this team was. They were just lost and I think they felt overwhelmed. So what I did is I just started working with them about every other week, and we would just talk through things and look through things. And so what we did is I can tell you, when I read their first monthly status report, I wanted to do a cartwheel because they had that aha moment, they had that breakthrough moment. And so they decided they wanted to do the algorithm to guide care decisions when the category 2 patterns occurred. And so, and it was kind of odd because they had a lot better buy-in from their physicians than they did their nurses. Their nurses were the one that was kind of resistant. The physician said, hey, we kind of did this in our head anyway. And she said, well, do you really talk to the nurses about it? And they're like, no. And so that was kind of their first PDSA. And they did look at 2 different algorithms, tried them out, decided which one that they were going to use. And then because the physicians kind of knew the algorithm in their head, but the nurses really didn't, they did some education and they put these algorithms in each delivery room. And so the first couple PDSAs that they did, they realized that, hey, our nurses need some more education. They were struggling with the tracings, and they were really not familiar with the categories and the definitions. And so that was probably one of their biggest breakthroughs is, hey, we need to get these nurses educated. The other thing was they identified that communication wasn't real great between ongoing and offgoing nurses. They had a lot of young, inexperienced night shift nurses. And so what they wanted to do is they wanted to improve that communication, especially amongst themselves, but also with their providers. So they did some team building with that. And the other thing they did, they went to bedside reporting. And so that has helped them. And so the biggest win is they did have 1 save from a primary C-section by using that algorithm. They know that because they used that algorithm that they did have a vaginal birth. And so, you know, as a team, we really want to celebrate the wins. And so what we did is we asked them to present at our all team call this month and kind of give their wins and what they did. And it kind of showed the other smaller hospitals that you can do it. And, you know, just one step at a time, but, you know, you can do it. So that is kind of how we've engaged the rural facilities. So if you have any questions, I know Dr. Radke has put our contact information at the end, but I will turn it over to her now.
Thank you, Jill. So what I wanted to kind of conclude with is discussing principles of community engagement that I think relate really well to the work we've been doing in Iowa. And I will say that this is not all, like, we didn't sit down and look at principles of community engagement and then lean into them. It was more when I was reading about it later that I realized we had actually employed a lot of of these principles. And I thought that that might be useful for people who are thinking about how to engage you know, kind of harder to reach groups in your own areas that you're working. So community engagement is really well described in the realm of community-based participatory research. And I just want to, you know, make the disclaimer from the beginning that we're not doing research with AIM or with our improvement work, but I think that some of the principles do apply to improvement work as well. Community-based participatory research, or CBPR, is really kind of a research philosophy, an approach that equalizes the power relationship between, you know, those who are the researchers, those with authority, often people in academics, and communities that they might be researching on, essentially. CBPR is not a specific research method. It can actually be applied to all research methodologies. And I think one of the big points is that CBPR is not a community outreach strategy, to help you achieve one-way transmission of information. It's really a path to truly partner with the communities that are important to you and develop those relationships. And so some of the things that we did early on that I wanted to highlight that we've mentioned is, starting with what our improvement topic was. When we wrote our grant proposal to get our MHI award, I said that we would start with a postpartum hemorrhage bundle. But when we surveyed our facilities and asked them, of these initial 3 or 4 core AIM bundles, which one would be most important for your facility, they chose to work on C-sections. And so that's what we're working on. And then, as you've heard, we've also had to really adapt some of the core components of the AIM bundles as written, and really of how improvement work has been written about in order to make it work for low volume facilities. So these on the slide here, these are 10 principles of community-based participatory research. It's pretty common in writing about CBPR to see between 8 and 10 principles that are largely the same. I'm not going to read this slide to you, but I highlighted a couple on the next few slides to talk about how we really applied that principle in our work. So the first thing that I wanted to kind of explain a little further is thinking about increasing your level of community involvement. And I think we've talked about this a lot through this conference and through other MLink events that, at the one end, it starts with outreach, where you're really just trying to set up communication from you to your community of interest. And you're generally just kind of coexisting with them. And then working across the spectrum towards true shared leadership, where you really have a bidirectional relationship between, whatever your academic group or your public health entity group is in the community of interest. The community is the one who's making decisions about really important decisions, such as how funding is spent or what priorities there are for projects, and you're really looking for outcomes that have that affect the broad community, not just those who are participating in your program. And I would not say that we are at this level with our community hospitals. However, I think that we are kind of in the involved to collaborate level. One of the biggest things is hiring Jill as a strong representative of the rural birthing facility kind of community, is that we have brought a member of the community into our leadership, because myself and Steph Trusty really do not have experience working in low volume facilities. And so we cannot ever claim to be experts on how things work in those facilities and how they should go about improvement. And then we've taken a lot of feedback from our teams to really to alter the program to meet their needs. And so there's been a lot of bidirectional communication and feedback that has gone into our work. So kind of getting at the point of our work and bringing Jill on is that we recognize that rural and level 1 facilities are kind of a unique community within our state, and that folks who work in those facilities, that's a unit of identity. And so we need to really acknowledge and lift that up. However, we want to be conscious of the fact that there's a lot of diversity within rural facilities. And so we have, as demonstrated on our graph, we have high and low capacity teams. We have high and low performing teams. And so we want to recognize that there's not a one size fits all approach. But that we want to lean into some of the strengths that are there in some of our small facilities. And then we're really trying to build upon the strengths that already exist in rural facilities. We know that rural nurses are often incredibly flexible, and that there is an immense culture of teamwork within small facilities. As Jill was describing, people work in lots of different areas of the hospital. They probably have a very wide breadth of knowledge, but they may not have as much depth of knowledge. And so we're really, as again illustrated by Jill's talk, we're really helping these teams to identify what are the strengths that they have within their own community and how can they leverage that for improvement. And then for teams who are really struggling a little bit, this promoting the co-learning so that they are witnessing their peers have successes, and that may help them gain ideas about strengths that they have and maybe had not recognized previously. Again, a key principle of CBPR is co-learning and empowerment, which really directly applies to the concept of improvement collaboratives, because the whole idea is that everybody is learning from each other. It is not a top-down information sharing. We certainly started by bringing together the best practice guidelines, but really we are trying to lift up examples of teams having success applying the principles of improvement. And so one thing, again, particular to rural and low volume facilities is that they may not have really seen where their place was in this type of improvement work. We know that the hospitals in Iowa were already very well aware of the AIM bundles, but they may not have seen where that work was for them. And so we're really trying to lift up how this work is for them and how we want it to be for them as well. And then we have, this is a long-term process. And so one of our key goals, again, going all the way back to what Steph started with, is we really want to build and establish a strong infrastructure for quality improvement, which really means we need our teams to have gained capacity to do this work themselves, so that as we move on in the future, they are empowered to identify priorities in their facility and continue to do improvement work. And then we also have several other structures that we have put into place, such as our data center, that will help us with sustainability in the long run. So we are about at time, but I just wanted to put in one last little slide here that, really what we're trying to do with improvement work is implementation science. We are trying to take best practices that have already been well established in the literature, often for many years, and help them be adapted broadly. And some of the challenges that face implementation scientists is relating to actually putting these things into place in a very diverse set of facilities. And this is where community-based methods really come into place, because the community needs to figure out what, what from the best practice they want to put into place in their facility and how that fits within their own unique culture and staffing model and other structures within their facilities. So I'm not going to read this table, but I think that to me, this was a really big connection point to think of how CBPR can help with implementation science. So this is all we have. So in conclusion, we consider here in Iowa that our rural and low volume centers are really vibrant and important birthing facilities in our state. Inclusion of these facilities in our collaborative is very important to address rural urban disparities in morbidity and mortality. However, you need to adapt the methods and the approaches that were often developed more so thinking about high volume centers in urban areas so that they can be better implemented in a low volume setting. And reading a little bit more on community-based participatory research may result in some kind of guidance about how one might do this. So that is all that we have. I'm sorry we went slightly over. Our contact info is here. And yes, we'll happily share our slides for anyone who's interested in them.
Thank you, everyone. That was great. I know we don't have a ton of time, but I do want to stay maybe a little bit afterward for questions if the speakers are okay with it. Everyone else, feel free to hop off and go to the next session whenever you're ready. Or I think this is the last session of the day. So the slides will be available online. The recording and the slides will also be posted to the website, the MHLIC website, and the event website. In about 2 weeks, because we'll have to edit, I think, the recording a little bit. But otherwise, any questions for any of our speakers about their methods? I saw a couple of things about different populations of interest. If you do have a question, please unmute yourself. We'd love to hear your thoughts.
Hi, Debra. It was nice to see your name pop up in the attendees here. Debra from IHI, who's hiding in her black box, is one of our coaches from IHI.
And I'm also scrolling through the chat. I think all of the questions were answered. So that was really great. Y'all were on top of it in that way as well.
We've gotten a lot of experience in Zoom sessions, so we're good at dividing up and answering chats.
That's great. So have you done this presentation or a modification of it at all? Oh, okay, great. So this is the first one. Great. It's important stuff. Okay, well, if no one has any other questions, I'm going to let everyone get back to their lovely Tuesday. And thank you again, Stephanie, Jill, and staff. We are so glad you were here, and the exciting work that you're doing in Iowa is an inspiration to us all. So keep up the great work. All right, bye everyone.